Hello, and welcome to the Princeton Spine Joint Center podcast. My name is Scott Curtis. I'm the Director of Sports Medicine here for the group. I just had a fantastic conversation with our newest practitioner, Dr. Greg Kelley, who has joined us from Georgetown Hospital System, where he specializes in musculoskeletal medicine. Dr. Kelley and I had a fantastic conversation about elbow pain, talking about the general approach that we take for patients with elbow pain, what are some of the different pathologies, some of the different diagnostic tests, and different treatment plans for individuals with elbow pain. So I hope you enjoy this. Hello, and welcome to the Princeton Spine and Joint Center podcast. I'm Scott Curtis. I'm the Director of Sports Medicine here for the group. We have a very special guest here today. I'm joined today by Dr. Greg Kelley, our newest member of the practice and a good friend and colleague of mine. Dr. Kelley and I will be talking today about elbow pain and kind of our approach and just a deep dive into elbow pain in general. So, Dr. Kelley, welcome.
Thanks
not only to the practice, but also to the podcast. So before we kind of get into the topic of conversation, which is elbow pain, tell us a little bit about yourself and how you got into musculoskeletal medicine and how you came here to Princeton, New Jersey.
Sure. So, when I was in medical school, I wasn't really sure what exactly I wanted to go into.
Yeah.
There's a lot of different options, as you know. And I came across PM&R, physical medicine rehabilitation, which is the residency that I completed recently. And it seemed a good mix of all the things that I liked about medicine. It had a good mix of sports medicine, orthopedics, neurology, and it was kind of a mix of all those things that I like. So I picked PM&R and just completed my residency at Georgetown University last year, and now I'm here.
Yeah.
And my interest is musculoskeletal medicine. I like seeing athletes, sports medicine, general musculoskeletal care. And I have a particular interest in diagnostic ultrasound, which is especially relevant to the elbow. It's easily accessible.
Yep.
So that's my interest, and I'm happy to talk about elbow pain.
Nice. All right, so let's kind of dive into it. You and I, we've talked about elbows at great length, amongst us when we talk about different types of cases. But let's kind of just go through a general approach. So let's say you're seeing a patient, you look down at your schedule, and it's, I'm just throwing this out there, a 40-year-old, gentleman who has elbow pain. What's kind of your thought process, and how do you kind of go about approaching this?
Sure. So, everything kind of starts with a history and physical.
Correct.
So like to get a nice detailed story of how long the elbow pain has been going on, any exacerbating activities or any particular motions or positions that seem to make symptoms worse. Any kind of medical history that could perhaps be playing a role as well. So you want to make sure that, you get a very full history, and that will kind of lead you down different, potential diagnostic and treatment pathways. So I always like to get the story first, and then, of course, the physical exam is also important. There's many structures in tight proximity in the elbow, so you want to make sure that you're accurately, discerning the problem area and using different physical exam techniques to do so. And then, of course, ultrasound is great for the elbow.
Yeah, we'll talk about different diagnostic
so
tests.
I like to always incorporate that as part of my physical exam too, to see if that can lead me again towards one particular diagnosis over the other.
Sure. Yeah, I mean, look, when we think about the elbow, everybody thinks that it's such a simple joint. It's really not. It's kind of the reciprocal to the knee, in the sense that they're hinge joints. And we always take the elbow essentially for granted until it's painful.
Right.
And then once you realize that it could be painful, it really, really could be bothersome and really hinder some of the activities of daily living.
Sure.
The approach for the elbow is really no different than, as you're saying, any other area within the musculoskeletal system. I personally think that 90% of all diagnostics come from taking a good history and a good physical examination. And then we will order different tests or do different kind of treatments, based on to either confirm the diagnosis or to determine how bad things are.
Sure.
For me, you know, one of the things that I always look for is this acute or is this chronic?
Yes.
Because it's important to establish how long this has been going on for, and you know, different types of injury patterns or different types of chronic degenerative issues will have different treatment things. So usually in younger individuals, and I'm going to kind of put on my sports medicine hat on for a second, you know, especially adolescents and overhead throwers, you know, baseball players, you know, quarterbacks, things like that, they're kind of in a completely different
Right,
class of
exactly.
elbow just because of the mechanics of
Right.
things. As opposed to, you know, older individuals who may be working a lot with their upper extremities, maybe doing, you know, a lot of manual labor, manual therapy, will have more kind of an overuse type pattern of injury.
Right.
So to me, it's important to really determine some of the timing of things and some of the exacerbating factors, like you said.
For sure.
And then the other thing, you know, that really kind of sticks with me when we're talking about the elbow is what are some of the other areas within the upper extremity that might be painful. So we'll talk, I'm sure, about things like golfer's elbow and tennis elbow, where it's not just isolated to the elbow, it's also forearm pain, and it could even go into the wrist.
Right.
How do you kind of approach or think about primary elbow issues when a patient's also complaining of shoulder pain or wrist pain or neck pain?
Yeah, so you know everything's connected. So and you can have referral of pain patterns into distributions of especially the tendons and the nerves as they come down the arm. So if someone comes in with elbow pain, you have to also check. Generally you always check the joints above and below the primary focus site to make sure there isn't any pathology that you might be missing if you're only focused in on the elbow.
Sure.
So, for example, a good example of this could be ulnar nerve entrapment.
Okay.
So, some people don't have any elbow pain at all with that, although the primary site of pathology is the elbow. They might feel numbness in
Sure.
the fingers, for example.
Yeah.
And you know, if you're not looking out for those things, if you're only focusing on the hand or the fingers, then
Right.
you might miss the underlying diagnosis. So it's always important to look at, like you were saying, the whole picture and make sure you're not missing anything.
Correct. You're not just two elbows and two shoulders, you're the whole body, as you're saying. And sometimes that's a little bit difficult for patients to understand is, they'll come in and say, yeah, my pinky is falling asleep. And I'll say, okay, how's your neck feel? Well, my neck is fine. It's my pinky. Okay, how's your elbow? No, doc, it's the pinky. But all of the nerves that they travel from the neck all the way down the arm. And the elbow in particular is a very vulnerable place just because the nerves are so shallow
Right.
that, if you bang your elbow and you hit your quote unquote funny bone, that's actually tingling the ulnar nerve. So certainly the elbow in itself is vulnerable to nerve pathology that may not present as elbow pain. It may present as something else, as you're
Exactly.
saying. So as a practitioner, it's important to look at the overall picture, which, is something that we should do on a regular basis. But I think the elbow is one area of the body that we have to really pay attention to because the upper extremity anatomy is just so complex. So one of the things that I often see is lateral epicondylitis or tennis elbow, and kind of the reciprocal of that is medial epicondylitis or golfer's elbow. Can you kind of describe or explain to patients what that is? And because it's just so common and we see it a lot here in this office.
Sure, yeah, very, very common. And so lateral epicondylitis or tennis elbow is a tendinopathy.
Okay.
Same for medial epicondylitis or more commonly known as golfer's elbow. And basically, there's two types. There's two types. There's acute tears where people generally notice at a specific moment where they have pain in the area of the elbow, either the lateral or medial elbow, or you can have more of the chronic forms where generally it's an overuse injury where basically the tendon's unable to withstand the load that you're putting on your elbow,
Right.
and you're developing micro tears and replacement of the underlying tendon with usually it's fibrotic tissue or scar tissue,
Right.
and that can be painful. So generally, tennis elbow is usually a backhand stroke where it's very common to develop pain, usually with wrist extension as you're coming through the impact zone of a tennis stroke on the backhand. And most of your wrist extensors attached to the lateral epicondyle.
Right.
So if you're overusing that area or you're having poor form,
Yeah.
you could be putting undue stress on the tendon as they insert onto the lateral epicondyle.
Yeah, and in my experience, especially as a sports doctor, the people who develop this, most of them actually don't play tennis. Because if they're experienced tennis players, they'll often have very good form, very good mechanics. They have a racket that works for them, so they don't develop this kind of overuse, which happens with poor form a lot of times. And it's not just the backhand when it comes to tennis elbow. A lot of times it's the forehand or receiving the ball. Because when you have your racket and you're hitting or receiving a forehand, what happens is if you don't have good wrist mechanics or you're kind of allowing the back of your hand to go backwards, you overuse and you go into extension too often. And let's say you're hitting 70 balls or 100 balls in practice or something, that's going to be a lot of load. And again, this is where we talk about the whole upper extremity being one, continuous unit, is if you're doing excessive extension of the wrist, it's going to put a lot of pressure or tugging at the end of the other rope where the tendons meet into the epicondyle or the big bump where the elbow is. And that's where we develop kind of this overuse and repetitive strain. But in my experience, most experienced tennis players, they don't allow their wrist to go in extension every time they hit, or they have a good racket that's not too heavy.
Right.
Part of what I do when I'm counseling a patient and I make the diagnosis of lateral epicondylitis is talking about the different mechanics and different equipment that's being used, and try to prevent some of these underlying issues to prevent them from making the tendinopathy worse.
Sure. Such as altering your string tensile force or your the handle of the tennis racket can make big differences for that.
Of course, or a lot of times if there's overuse and they're playing, let's say 6 times a week, they're playing for 2 hours, scaling back on it or trying to mix it up with doubles. That way they're not, playing too much. But inherently, it's an overuse injury that can be corrected sometimes with simple mechanics.
Sure.
Same thing with the reciprocal, which is golfer's elbow or medial epicondylitis. If in lateral epicondylitis or tennis elbow, it's the extensors. In golfer's elbow or medial epicondylitis, it's more the flexor pronators.
Right.
And as you and I have talked about, because we both love playing golf, that if you have poor mechanics or poor form as you're going through and you turn your wrist too often or too hard, you're going to develop medial pain.
Yes.
Any tips for our amateur golfers out there and how to prevent that?
Sure. So I love golf. Let's just start out by saying that. So I think a lot about golf mechanics and the golf swing. So generally, how I see it is that when you're coming through the impact zone of your golf swing and you're generating a lot of wrist flexion and pronation at the impact zone, which is the most crucial part of your golf swing, is what happens right at impact. If you're generating a lot of flexion and pronation, which is the motion of turning your hand downward, then you're likely, and this is aside from just dealing with the pain of medial epicondylitis, but if you're doing a lot of that, your club face is probably not very square at impact because you're turning your hand over, and therefore you're basically turning the club face at an angle through the impact zone that's not going to allow you to have accurate shots.
That's why I shank the ball all the time.
Yes, I do that as well sometimes.
Yes,
it's very embarrassing.
Yeah.
So what I like to tell people, this is, again, might not even be related to medicine or pain, but to have more of a truncal movement through the ball where you're not necessarily turning your hands and wrists over at impact, but more your body is bringing you through the impact zone with steady with a steady rate of closure of the club face where you're not turning it over, but you're more letting your body, which is the powerhouse of your body, give that, and that will allow you to have more power and increase the distance of your golf shots as well.
With more accuracy.
As well. And
using putting larger muscle groups.
Exactly. Yeah. And putting less strain on those flexors and pronators. If you were to develop pain in that region as well.
Right. And so that's kind of the underlying mechanics of it, why people develop it. What happens now, let's say you have the patient, you make the accurate diagnosis. What's kind of your approach to either managing or treating either, let's say, lateral epicondylitis or medial epicondylitis? What's kind of your approach?
Sure. So again, like you said, acute versus chronic and differentiating between those two is very important. So if someone comes in with acute pain in the lateral epicondyle or medial epicondyle, I'll treat that person differently than somebody who's had months or maybe even years of pain in those areas. So for people who've had maybe an acute tear of the tendon, I generally will give a relative period of rest, anti-inflammatories, maybe brace them to limit the motions of the wrist that could be exacerbating the problem. And basically, watchful, a wait and watch approach to see how they do over the course of maybe, a few weeks.
Okay.
And I'd like to get them to physical therapy as well in a relatively short time frame as well to see if we can strengthen the area.
Sure.
The chronic cases can be a little more tougher to treat.
Correct.
Because you can have, they've shown in studies that the tendon has a different histopathologic appearance.
It's a big word.
Yes, biggest word out. So it's not the normal tendon with the intact collagen fibers that you see in healthy tendon. There's a lot of increased fibroblasts and other cellular material in the tendon, and again fibrotic tissue and scar, and that can be hard to treat.
Right.
So generally for those people, I like to take a little bit more of an aggressive approach with them and considering other techniques that we have to try to stimulate healing in that chronic degenerated tendon. Some of those things being needle tenotomies.
Okay.
And then there's, of course, a bunch of injection techniques that we're starting to do more and more in the field of sports medicine, musculoskeletal care like prolotherapy and PRP and those types of things. Again, with the goal being to try to incite an inflammatory reaction to bring about eventual remodeling of the tissue to more of a normal tendon.
Right.
So, of course, you can also try things like physical therapy, and that could work along with bracing, but sometimes those patients might need a little bit more of, they might need a certain other type of treatment to help with that process going forward.
Correct. Yeah. I mean, the way I look at it, and I think you hit the nail on the head, again, just trying to discern or differentiate acute versus chronic, right? Typically, long-lasting problems will take longer to heal. Shorter, more acute problems, in some cases, will take shorter to heal. And if there's, an acute issue, the mainstay of treatment, at least from the conservative aspect, is what's called RICE therapy, which is an acronym that stands for rest, ice, compression, and elevation. For a period followed by things like physical therapy, anti-inflammatory. I'm a big fan of things like counterforce bracing, which is a brace that doesn't go right over those big bumps, the epicondyles, but actually a little bit further down to offload the tendons as they attach in there. And a lot of patients will do well, especially with the conservative treatment, but it may take time. That's some frustrating points for patients, both from an acute and chronic perspective. The chronic issues, as you're saying, can be a little bit more complicated in the sense that there's a lot of turnover within the cells and the architecture. And one of the things that I'll often get is actually a simple X-ray of the elbow. You can't really see the tendons on an X-ray. The X-rays are really good for looking at bones and for joints, but you can see very subtle clues of chronic things, specifically calcifications. Because if calcifications are present on X-ray, it means often it's a chicken or the egg type thing. Did the inflammatory response and the long-term process cause the calcifications, which you can now see and potentially break up? Or have you had this calcification that's causing your pain now that needs to be broken up? Right. So a lot of times if patients are not progressing in the acute phase and it's now becoming more of a chronic picture, I will get an X-ray just to see is there any kind of calcification. And unfortunately, a lot of times, if we want to evaluate further the soft tissue stuff, insurance companies say we need to get an X-ray first, just to make sure that we're not missing anything. I hate dictating care based on insurance companies, but a lot of times they're right, and get an X-ray first because it may help kind of lead you down that pathway of a tenotomy or breaking up that calcification. Right. So we've talked about the conservative approach in terms of, therapy, counterforce bracing, anti-inflammatories. You touched upon injection therapy. We will often do corticosteroid injections to treat a lot of musculoskeletal issues to reduce inflammation. Does that really help in terms of epicondylitis and treating that?
Well, it depends what your goal of the cortisone injection would be.
Okay.
So studies have shown that cortisone can help with acute pain in the short term and in periods of a few weeks to a month, and getting people's pain levels down, and maybe then they can tolerate a physical therapy regimen better, and basically improve their symptoms through therapy and exercise by being in less pain. Over the long run, though, those patients don't necessarily do better than people that do nothing at all, just rest or other injection options such as PRP as well. So they've compared those two interventions, or several different interventions, cortisone versus rest, cortisone versus PRP, and the cortisone group doesn't do better than those other interventions. So generally, what I do, if people, and they've also shown that cortisone injections over time could have a deleterious effect on tendon healing.
Sure.
So I'm careful with cortisone injections, especially with tendinopathies, but I will do them if the indication is right, and if people are just in a lot of pain, and hopefully we can get them into physical therapy, which is helpful.
Yeah, I think you and I are on the same page with that. In that, we try to practice medicine based on the studies. And there are places that we know that cortisone really works well, and it's kind of exactly by the textbook of, it'll help reduce pain and inflammation for, let's say, 3 months or so, depending on the area. The studies don't show tremendous benefit of corticosteroid injections for lateral epicondylitis, and there's even less data out there for medial epicondylitis. I will tend to do a corticosteroid injection if the patient is unable to tolerate physical therapy,
Sure.
and they've exhausted a number of different types of oral or topical medications, or they can't take an oral anti-inflammatory. But I will often caution patients that this may not work, number one. Number two, if it does work, it may be short-term benefit. And number three, if we have to do multiple corticosteroid injections, it's not a good thing, and it could actually make things a lot worse. A lot of times the patient I'll do a steroid injection for lateral epicondylitis, and they'll feel great, let's say, for 3 months. And during that 3-month span, they didn't want to do therapy because, hey, they're feeling great. So then their problems come back, they get back into their physical activity, and they'll say, "Doc, give me another shot." Talk about the risks and benefits, and we decide to do it. Now the second injection is lasting, let's say, a month.
Right.
They come back a month later and say, "Doc, that helped, but not as much, or it didn't last as long. Let's do a third one."
They're not addressing the underlying
Correct.
pathology.
We're just trying to cover it up,
Right.
and that's clearly not the way to practice medicine, or not how I like to practice it. And so I'll often tell patients, look, if we're having to do multiple injections, or it's not working, or it's just not doing what we're hoping to do, that's not the way we do things. So we'll have to kind of take a different approach. Sure. Now, in terms of the studies, with cortisone injections or corticosteroid injections, the goal is to reduce inflammation and reduce some of the pain and swelling. Now, with PRP or some of these regenerative injections, the theory is the complete opposite, right, where we're not trying to reduce inflammation, we're actually trying to incite healing and incite inflammation. Right. What are some of the studies behind PRP injections for epicondylitis?
So it's shown the data is variable with a lot of PRP studies in various areas of the body, various tendons, various joints. A lot of that having to do with the makeup of the PRP substance as well. There's different forms. There's different concentrations of platelets. There's leukocyte-rich versus leukocyte-poor PRP. So the data is not uniform. So it's hard to assess, with a single study. However, they've shown that PRP can have a beneficial effect, especially at later time frames for lateral epicondylitis. And again, the idea being that if a tissue is chronically degenerative and there's scar tissue there, the only real way to heal that is to try to bring in an inflammatory response, right, to try to remove that tissue and to try to remodel that tendon to bring it back to its normal structural integrity. Yeah. So that's kind of the idea, and it's shown pretty good evidence for PRPs for certain areas of the body, lateral epicondyle being one, the Achilles tendon being another, the patellar tendon being another, and the knee. So there's certain areas where it has shown positive results, and I'm sure in the future it'll only, once the studies start to become more uniform in terms of the actual chemical makeup of the injectate, then the data will be even clearer. But it's shown promising results so far.
Yeah, I think that, and we've talked on this podcast about PRP, and we've really done an in-depth dive in it previously. So I don't want to focus too much on of it, but I think epicondylitis is one of those areas that is really showing a lot of positive data behind it. So when I'm seeing patients and, we're trying a lot of different things, and we've got the MRI that shows, mild chronic epicondylitis or, even a tendon tear, we'll often have the conversation about the risks and benefits of PRP as opposed to either one, trying more steroids, which isn't working in this case, or trying more conservative treatment, which, might have helped, but the patient has plateaued, versus another option, which is surgery, which really isn't a great option for a lot of cases, for these chronic cases, because there's not even a discrete tear that needs to be surgically fixed. A lot of times it's still the process of healing and breaking up that scar tissue. So PRP, is certainly a very good option for a lot of patients who have this chronic tendinopathy. I kind of want to switch gears in terms of a specific population, which are throwing athletes. So we see, a lot of, I see a lot of baseball players and softball players, overhead athletes. And some of the things that I see are not necessarily just tendinopathy. I see a lot of overuse and ligament issues. How do you kind of go about a patient who, let's say, loves playing baseball? Is there anything that you could advise them in terms of throwing and, mechanics that they might be able to work on to prevent issues?
Sure. So very common to develop medial elbow pain especially with the baseball motion, which is quite unnatural and involves a lot of stress at the shoulder and at the elbow. So one of the main ligaments in the elbow that gets injured is the ulnar collateral ligament, the Tommy John ligament.
Right.
And that basically develops due to extreme valgus or motions that involve extreme kind of motions of the elbow that can stress the inside of the elbow.
Yeah.
So that's a very common referral to orthopedic surgery, but we like to try to avoid that as much as we can with more conservative options.
Sure.
So,
especially in younger individuals,
younger people, right?
Yeah, exactly. What you're describing as valgus extension overload, we'll often see pitcher's elbow or little league elbow, it's called, where there's just too much stress on that area. Like you said, the pitching motion or the throwing motion is quite unnatural. We could talk, on a completely different podcast about the effects it has on the shoulders, but on the elbow, I'm constantly seeing it in younger individuals who have a high pitch load or are throwing different types of pitches,
Right.
Such as breaking balls, especially at an early age.
Sure.
There's a lot of risk factors that put strain on the elbow, which doesn't necessarily need surgery or injections or anything like that. All it really needs is some counseling and some rice therapy and some anti-inflammatories and some tweaks in the pitching mechanics. And I think that's it's something that we take a lot of pride in as doctors, is educating our patients and working with them. And I think that this is one area that we could really do a lot of good for in a conservative, non-invasive way, and teaching not only the baseball players or the pitchers, but also sometimes their parents too.
Right.
In terms of, and coaches, in terms of pitch count, in terms of not introducing breaking balls early on at such a young age, and relative rest throughout the year.
Sure.
I see a ton of athletes who, the star baseball player, they're the pitcher, they have to pitch all year round. They're not only playing in the spring and summer, they're playing fall ball, they're now in winter leagues. They never give their arm a break. Or they're playing, but they're also the star quarterback, and doing the exact same mechanics.
Sure.
I've read James Andrews, the famous orthopedic surgeon, often will talk about, taking 4 months out of the year and doing a completely different sport from what you're doing, and not being the baseball player and the football player who has the exact same throwing mechanics, and then doing javelin in the springtime, the exact same mechanics, because you're just overloading the same exact elbow thing. So I think that there's a lot of counseling that we could do for rest, for mechanics, and that can help not only with the acute pain that the player, or the chronic pain that the player is facing with, but also preventing it going forward.
Sure. Yeah, and especially as kids get super specialized at an early age, there's a lot of pressure on them to not only perform, but perform well at a very young age. And often that comes with more throwing, higher pitch count, trying to impress scouts, trying to impress their coaches. So especially in those younger populations where the bones are still growing and the growth plates are still open, we have to be especially careful with those athletes and making sure we're not overloading their joints and their ligaments with too much throwing. So that again, education, even for the tendinopathies that we were talking earlier. I mean, just talking to your patients about what causes these things and trying to limit activities that could be worsening their problem is probably the number one thing you need to do over anything else, because it's an overuse injury. So by limiting the use, that's basically, it should be the number one treatment. So very important, like you said. I totally agree with you about teaching patients about what is causing this, and they can then use that in their life to try to limit those things that are causing their underlying problem.
And that's frustrating for patients, obviously, because everybody wants that magic pill or the magic injection that's going to take away all their pain so they can continue doing what they want to do. But a little bit of prevention is really, and a little bit of counseling is really kind of the most important thing that I believe we could do as doctors.
Absolutely agree.
And just to touch on some other things, it's not just the ulnar collateral ligament that we worry about in these young kids. A lot of younger individuals could develop OCD lesions or osteochondral defects in the elbow. They could develop, strains of the muscle, strains of the tendons, and they could develop nerve issues as well because of all these chronic inflammatory issues or chronic pulling on the nerves. So it's something that we need to counsel and prevent any kind of injury.
Absolutely.
So that kind of segues into the nerve pain that I wanted to talk about. One last thing, in terms of elbow and referred nerve pain. We talked about the ulnar collateral, how it kind of goes down. Do you often see patients who are feeling pain in their elbow coming from higher up in the chain, either at the neck or in the shoulder?
Yes, it's common. The nerves in your neck, they go down and supply the entirety of the arm, and there's a certain nerve which can come down on the inside of the elbow where the ulnar nerve lies. So just like you were mentioning earlier, you want to make sure that there isn't any compression of one of the nerves in the neck that could be causing or confounding medial elbow pain as a simple, or not simple, but a nerve entrapment at the elbow, when really it's a referral pattern. So there's certain things that can tip you off to that in their history and physical exam. If there's a lot of neck pain, especially with range of motion, if there's pain that extends down the shoulder, and a referral pain distribution or dermatomal distribution, that can help kind of elucidate as to whether it's coming from a neck source or more of a focal entrapment in the elbow. You can, palpation of the elbow and trying to provoke paresthesias or nerve-like symptoms by tapping in the elbow like a Tinel sign, and if that causes your symptoms, then it's more likely than not is coming from the elbow.
Yeah, like a cubital tunnel syndrome.
Exactly. So because the nerves are all coming from one source up in the spinal cord, you can have these patterns that can be a little bit confusing, but usually with a good history and physical, you're able to tease that out.
And there's some diagnostic tools that we could use to help, right? This is where an EMG or a nerve conduction study could play a significant role. Which is, and we've done, Dr. Mailer and I have talked about this on our podcast, where we can measure how fast the nerves are traveling down the arm, starting from the neck all the way down, and see if there's any kind kind of slowing around the elbow or around the wrist, or to see if there's any kind of entrapment or clues for it. Then we also could look at the different muscles and see if there's any kind of irritation with them.
Right.
But I think a nerve conduction study is a very good way to look functionally at the entire upper extremity, but specifically around the elbow as well. And then if there is concern about any kind of nerve entrapment, this is where the diagnostic ultrasound might be helpful, because you could get a picture of the elbow, right, either with an X-ray or an MRI to look at some of the soft tissue structures. But a lot of times when you're taking a still picture, you may not see the pathology. The value of an ultrasound is that you can do it in static maneuvers, dynamic maneuvers. So it's not static. It's you're moving it around, and if there's a muscle that's now pushing up on the nerve as you're moving it, that could be clinching the diagnosis of a nerve entrapment.
Right. Oftentimes, I do exactly that. I look for the nerve, and the nerve tends to sublux out of the elbow over the medial epicondyle inflection.
Yeah.
So again, a dynamic ultrasound of evaluating that nerve in both extension and flexion to see if the nerve is subluxating over the medial epicondyle can give you clues as to what's going on.
Yeah.
You can also see if the nerve is swollen at that particular area and compare it to a non-entrapment site lower in the forearm, and there's certain ratios that you can calculate to diagnose that. But ultrasound is a great technique, along with EMG, to using all these tools together to try to come up with a diagnosis. But ultrasound is great because these structures are all relatively superficial and relatively easy seen with ultrasound. So,
and this really will help because if I'm going to do a test or order a test, I want it to change my management in some capacity. I think that's really helpful to not necessarily do, again, any kind of injection or change where we're going, although that sometimes is helpful, but really provide a physical therapist or a chiropractor with some information about, hey, there's an ulnar nerve entrapment at the elbow. You might want to try doing some nerve gliding techniques as opposed to just a pure strengthening program for an epicondylitis picture. So I think it does add value in terms of our management and providing, our colleagues who are really on the forefront of treatment in terms of the manual therapy with as much information as possible so that they're able to do their job. So we talked a lot about different types of elbow pathologies. We talked about kind of our approach, different treatment options. Do you think that there's anything that we might have missed or overlooked in terms of kind of our general approach to elbow pain?
Well, again, there's a lot of structures in the elbow, so it's very important to get that history. That you have your biceps tendon attaching on your radius. You have your triceps tendon that attaches in the backside of the elbow. There's other kind of nerve entrapments in the arm that are very rare, but it's possible. Median nerve entrapments in the forearm. So there's all kinds of pathology there that could potentially be playing a role. But we've hit a lot of the major reasons people get referred to us for elbow pain.
At least the more common things.
The more common things, right? Trying to think if there's anything else we should talk about that we haven't hit on yet.
I think we kind of gave the audience, the listeners and the viewers a general overview, and hopefully nobody's coming in here with some of the rarer things that you're discussing. I think it's important to really kind of, like we've talked about, just take an overall general approach, focusing on the whole body, getting a good history, a good physical examination, sometimes getting diagnostic tests if we think it's going to change our management or we're concerned about something else going on. And then, trying the conservative approach first when appropriate, or, different types of injections if it's more of a chronic issue and if it's appropriate. And sometimes things do have to be sent and referred to an orthopedic surgeon for an actual surgical fixation or, reconstruction of ligaments, things like that. But we've got to keep in mind that everybody's an individual, and we have to look at everybody as an individual and do what's best for that person.
Absolutely.
All right. So I want to just thank you for coming on for the podcast.
Yeah, thanks for the invite.
I think we're going to do many more of these together. Hopefully we do. And thanks for coming on.
Absolutely. Thanks, Scott.
All right.